Right. Good afternoon, everyone. Can you hear me, ladies?
Yeah, I hear you.
Yes.
Okay. So we have two requests for discussion. One of them is about using diuretics in the case of heart failure and kidney disease. Okay. Now, let's start with the easiest one, which is end-stage kidney disease patients. There are two kinds of end-stage kidney disease patients. They are on dialysis. The number one is the one that patients with end-stage kidney disease on dialysis and they make urine. And the other one is progressed kidney disease on dialysis without the ability to make urine. If they cannot make urine, you cannot really do much about it. If they can make urine, you can use some loop diuretics or metolazone. Loop diuretics or metolazone, which is metolazone thiazide diuretic that has nothing to do with the GFR per se. And both of these classes of medications can be used. I'm talking about metolazone, not the hydrochlorothiazide or chlorothalidone, because if your GFR below 40, you really should not use hydrochlorothiazide or chlorothalidone, but you can use metolazone, which is separate or different. So you can use loop diuretics or like Bumex or Lasix or metolazone in patients with end-stage kidney disease and they are making urine. In general, our practice is if patient is on hemodialysis or peritoneal dialysis, we really leave diuresis and fluid management to nephrology. If you are forced to intervene, you have to make sure that your patient is able to make urine. If they're able to make urine, in that case, then it's reasonable to do loop like Lasix or Bumex or torsemide, or metolazone. But if they're not making urine, you really can't do much at all. Now, if your patient has chronic kidney disease, feel free to use loop diuretics or metolazone as much as you want. However, you need to monitor a few things. You have to check your BUN, and you have to check your creatinine, and you have to check your potassium, right? When they start having hyperkalemia in spite of diuresis, that will give you an idea that your patient is really volume contracted, and you have to be careful about that. If your patients start having BUN elevation, that might be an indication that they're becoming to be, just your patient is becoming more hypovolemic, so you have to be careful about that. And don't judge just based on creatinine alone, because Mr. John Smith may have HFrEF or HFpEF, and baseline dry weight creatinine is still 2.5. So don't go into this trap of these nephrologists where they felt that the creatinine is 1.2 is better for patient. Is not. You have to really, that's the dilutional kind of creatinine. In your mind, you have to think about that's not the good volume status for your patient, and your patient baseline or his dry weight creatinine is 2.7, so be it. Then just diurese until you reach 2.73 of creatinine level. And usually BUN starts before creatinine. And in terms of management, diuresis-wise, I would just cut down a little bit on the ACE inhibitors or the sacubitril valsartan, which is Entresto, in favor of beta blockers and diuresis. Any time you know that the old teaching in heart failure management that if your patient coming with CHF exacerbation, you have to cut down your beta blockers by 50%. I really don't do that unless you are in class 4 heart failure. But in general, keep your beta blockers, cut down on the ACE inhibitors a little bit or the Entresto a little bit. Don't bother your kidneys that much. Make sure to bother the kidneys by diuresis. Get as much fluid as you can, and then check the creatinine. So don't fall in the trap where you know the creatinine is better than you know you're okay, or you start diuresing and the creatinine starts climbing up in patient with CKD disease, and then you get panic. No, maybe sometimes you know the creatinine should be 2.7 for your patient to feel good, so be it. Is that clear?
Yes, thank you.
What, is there a reasonable, an increase in creatinine that is reasonable? Like, is there a certain percentage that you would typically like to stay under?
Not really. No, you have to, if you can reach your, if you know, if you will have an idea about your patient dry weight creatinine, baseline dry weight creatinine, that would be a good point. But sometimes if your creatinine, if your patient is like a dripping from everywhere and you know that they have volume overload, extravascular, you have to stress them. Sometimes if you're in hospital settings, what we use, we infuse some albumin on top of loop diuretics and try to diurese as such, because the albumin is gonna keep your intravascular volume higher, and you can suck more out extravascular volume down to the intravascular, then you can force this volume and sodium and fluids to the kidneys. But you know, it's never been proven in clinical trials that albumin can help, right? But we use it all the time and it does really work. The key is going to be, you know, elevation in creatinine is not uncommon in the setting of chronic kidney, especially African Americans have PEF. You know, that's the earliest stage. That's the, you know, sometimes whatever you do is not going to work, and you have to send your patient for ultrafiltration with dialysis. But I mean, be strong. I mean, if you feel that the creatinine is climbing up, so keep checking creatinine, just keep checking BUN, keep diuresing your patient, keep assessing the volume status, assess the urine output, make sure that your patient is not cheating by eating salt and drinking a lot of fluids, especially during this episode of CHF exacerbation. Go from there. It's going to become an art, but I disagree with the nephrologists that, oh, follow the creatinine, and then they get scared when the creatinine is climbing up. I mean, no, sometimes your patient is not going to feel well unless the creatinine is 2.7, because this is the dry weight, unfortunately, and your patient is bad luck because your patient did not really take care of himself or herself by taking blood pressure medications, managing diabetes and so forth. And sometimes it's too late, that a lot of kidney function is already gone. And what you see improvement in creatinine numbers, that's actually delusional, and that's not reflective of acceptable kidney function.
You know, I've seen it quite a few times where I'll diurese a patient and then creatinine goes up and primary consults nephrology. But that increase is likely transitory
Absolutely.
and expected.
Right. And I'm okay with it. We're always okay with it. And the nephrologist is gonna come, and either if he knows that you're a strong cardiology background, they will not bother you, and they will say avoid nephrotoxicities by NSAIDs and cut down the ACE inhibitor just for a short period of time, which is reasonable to do. But you know, I know nephrologists, they really care about the number of creatinine, which is just is lack of understanding of the basics of medicine, and it's very sad. Any questions about that? I'm gonna touch up on the somebody requested some information about amyloid. We really don't see it very often. Cardiac amyloidosis. Nowadays, we do have treatment for cardiac amyloidosis, and the way to diagnose cardiac amyloidosis, if you have patient with HEF, thick walls on the echocardiogram, a little bit of pericardial effusion, the atria will be dilated, is a notorious HFpEF, you can't treat, and some other uh, organ failure, such as a little bit of kidney disease, a little bit of liver disease. If you suspect any of that, you can do SPEP and UPEP, serum protein electrophoresis and urine protein electrophoresis by aminofixation. And then if that's positive, you do PYP scan. And I tell you this, I've ordered all of that at the Great Memorial Hospital and never had any test done properly. So it's just very difficult to diagnose as far as disease. We do have some medications right now. We have the Vendamax, which is, believe it or not, about $60,000 a month. Jackie, we tried that before, right? I think if Jackie is listening, we tried to order that, but we got pushed back, and we didn't know that $60,000. Obviously, nobody paid for the medication. And however, if you think that it's hereditary ATTR by doing the genetic testing, then there's some new medication going on, which this medication can be injectable 4 times a year. Like every 3 months, you inject the medication, and that goes to the cells, prevent the cells, especially the hepatic cells, to prevent the hepatic cells from actually excreting this amyloid protein and prevent disruption of the intracellular material by having this protein extracellularly. So it's kind of really complex. I can tell you that if you know that your patient has, for instance, multiple myeloma, and because of that they have amyloidosis, then you just send to hematology. Short of that, is extremely unlikely that we at this capacity are going to deal with amyloidosis. Any question about that? Any other questions in general?
Hey, Dr. Ibrahim.
Yes.
It's Jackie. Hey, I'm getting from the PCP, he's really not liking any calcium channel blockers and saying that's causing a lot of falls, even have said that it causes bradycardia, which I cannot find anywhere when I research. Do
The
you have any
dehydropyridine
thoughts
one?
about?
Yeah, listen, it's just, no, I disagree with that. The dehydropyridines ones, actually, the amlodipine, the nicardipine, uh, and other nisaldipine, they don't really cause bradycardia. The non-dehydropyridine ones, the cardizem and the diltiazem, they do. And the calcium channel blockers in general can cause lower extremity edema and a little bit puffiness. So we try to avoid them in heart failure with a lot of edema. They are wonderful blood pressure medications. Patients respond to them very well. And I kind of disagree with that. I don't know if losartan or lisinopril or ARB or ACE or spironolactone or any kind of diuretics gonna be less prone to give you orthostatic hypotension or fall, but I really disagree with that. And probably if this is the way they feel, then you gotta respect that, but that's not really.
Right. Okay. Thank you.
Yeah. In elderly population, we try to avoid diuresis. Diuretics, because of the nature of electrolyte imbalances and the kidney issues. And some of these patients, they really cannot express sometimes their thirst or their need for like muscle aches and so forth. To give you an idea that they are hypokalemic. So all teaching that we try to avoid diuretics in elderly patients, but not calcium channel blockers or ACE or ARB. I don't like beta blockers as blood pressure medications. They are weak, especially in African Americans, and they give the patients a bunch of symptoms such as headache. Such as fatigue, weakness, a little bit of weight gain, uh, but I don't think calcium channel blockers gonna have any bad effects to the point that elderly population should not be taking these medications. That's really not accurate.
I have a question.
Go ahead.
So for HFrEF, I have a patient whose blood pressure is not going to tolerate much. She's doing the lowest dose of Entresto. And so I don't see where I could add metoprolol. I could potentially get away with Farxiga. And do they have do they have to have diabetes to do Farxiga? I guess my question is, if you had to pick out of GDMT, what
Right,
absolutely have to have?
I think we've talked about it before, probably prior, maybe a long time ago. If you look at the clinical studies and the number needed to treat, actually beta blockers were number one. So the number needed to treat, if I'm not mistaken, 7 to 9 patients to have a difference in outcome. If you look at ACE inhibitors or ARBs, mainly ACE inhibitors, they're about 14 to 16, right? And then after that, the MRA, which is spironolactone, maybe 20 plus, and then the other medications about 30 to 40, such as the SGL2 inhibitors. So I would give them beta blockers, number one, ACE, ARB, or Entresto, sacubitril, valsartan, number two, aldactone, number three, and Farxiga, Jardiance, number four.
Okay, thank you.
Any other questions? All right. Ladies, we'll chat later, and thank you very much.